Welcome to Leading Voices in Healthcare and our special webinar on navigating healthcare in a post-Roe world. Leading Voices in Healthcare, presented by the TDC Group, is where healthcare industry experts share thoughts on the latest trends, data, guidance, and best practices. We'll get started with our program shortly, but first, a few housekeeping items. Please note the session will be recorded and the recording can be accessed by logging onto our website at thetdcgroup.com and clicking on the Insights tab for Leading Voices in Healthcare. Also note that by clicking the icons on the left of your screen, you can read the full bios on our speakers. Our speakers will each give a brief introduction to our topic today, and then most of our program will be a discussion. I'm now pleased to introduce Sheila Dejbakhsh, OBGYN at Orange Coast Women's Medical Group. Sheila.
Thanks, David. All right, hello everyone. I am very excited to be here. Thank you to the Doctors Company team and my fellow speakers. This is a very important topic, and I'm happy to be part of, in fact, honored to be part of this webinar and this discussion. So, as you know, as OBGYNs, we are women's healthcare advocates by nature. And this recent decision by the Supreme Court ultimately has shifted the landscape for a lot of our patients and providers who provide this care. So first and foremost, what I wanted to start with is that, abortions are not illegal after the passing of this the Roe V. Wade decision was overturned. Abortion is not illegal. However, it is no longer a constitutional right, and the onus goes on the states and possibly Congress to be the parties that will be helping create rulings for whether or not we're able to practice in this fashion. So I do have to, I am from California. I do practice in California. I am very lucky to be in a state where the legality of abortion is not going to be changed as a result of this ruling. However, even in this state, I am constantly reminding my patients day in and day out that it is not illegal, because it is this new ruling has created such a kind of a fear around the issue. So what's important for us to understand here, or kind of to discuss, I think, is to kind of learn to navigate and help our patients navigate through this new landscape where it may be harder for them to access care that they need in a safe fashion. Importantly, there has been studies over the risks that are taken by a lot of these women, whether it be economic risk, financial risk, but also the Turnaway study, which kind of focuses on the social, physical, mental implications of being denied abortion care. So with this new law that has come into effect, in addition to not having access to care, these women are even further marginalized in the increased risk that may be imparted upon them with being denied care. So with that, I would say, I'm very excited to get into this topic with my fellow speakers. Thank you so much, David.
Thank you, Sheila. I'd now like to welcome Daniel Grossman, the Director of Advancing New Standards in Reproductive Health, based at the University of California, San Francisco. Dan?
Thanks so much, and thanks for the invitation to be a part of this panel. So, as we know, in the aftermath of the Dobbs decision, a number of states have already banned abortion. I think there are about 12 states currently that have bans that are currently in effect. Others are being challenged in the courts. According to the legal experts, it's possible that as many as 26 states may ultimately ban abortion or severely restrict it. And each year there are about 300,000 people who obtain abortion care in those states. And of course, the question that everyone is asking is what's going to happen to those people. Obviously the potential, I wouldn't even call them options, but the outcomes for these people are, some people may end up traveling out of state to obtain abortion care. Some may choose to self-manage their abortion or self-induce their abortion. And others may are likely to essentially be forced to continue the pregnancy. The pathways associated with each of these kind of outcomes are really complex. And I just wanted to say a little bit, in terms of traveling out of state, if you look at the map where the bans are occurring, I mean, the distances that patients are having to travel now have just become enormous. Like if you consider, I'm sure Dr. Moyeti will talk more about this, but a patient who is in Houston who needs to access a first trimester abortion, now is looking at the nearest place for in-person care to be in Wichita, Kansas, which is about 700 miles away, about a 9.5-hour drive each way. If that clinic is too backed up, we're talking about other options that are potentially, over 800 miles away. So it's really just tremendous distances. And talking to people who have a lot of expertise in helping patients access care and providing logistical support before the Dobbs decision, it was really hard to get patients to travel much more than 500 miles. It was difficult to support patients to travel by plane, even if the travel costs were paid for the patient. And so it's really going to take a tremendous amount of work by abortion funds and other groups providing logistical support, both in the states where the patients can no longer access care, but also in the states where patients are being sent to receive that care. And they're really going to need a tremendous amount of support. Another pathway that patients may end up following is potentially self-managing their abortion. Fortunately, this looks very different in 2022 compared to the pre-Roe era. Now patients have the option of using the very same medications that we use for a facility-based medication abortion, either mifepristone together with misoprostol or misoprostol used alone, to self-manage their abortion on their own outside of a clinic setting. Aid Access is one online service where patients can go and enter their health information. This is a service that is operated outside of the US, outside of the US regulatory system. But then if they're deemed eligible for medication abortion, the medications are sent to them, generally from India. And that's one downside, that it can sometimes take 3 or even 4 weeks for the medications to arrive. There's a really interesting evaluation of the service that was recently published by Dr. Abigail Aiken and colleagues that found really that the outcomes with this service were almost identical to what we see in clinical trials of medication abortion, with effectiveness over 96%, safety rates, again, very good, with about 1% or less of patients having a serious adverse event. So, really as an OBGYN, I don't have any medical concerns about patients, or I don't have many medical concerns about a patient self-managing their abortion with these medications, provided they have good information about, how to screen themselves for eligibility, if they know what to look out for in case of a complication, and they have a place to access emergency care. But I do have concerns about the legal risks that patients may be taking by self-managing their abortion. And I hope we'll have a little bit of time to talk about how we as clinicians can play an active role in reducing those legal risks. And then finally, the third pathway, which is, I think, what probably the majority of patients will end up pursuing, patients who otherwise would have chosen an abortion, instead they'll be forced to continue the pregnancy. We know that this is inherently more dangerous and also associated with more socioeconomic risks, as Sheila just talked about. The risk of death associated with childbirth is at least 14 times higher compared to obtaining an abortion. Dr. Amanda Stevenson at the University of Colorado has modeled the effect of a nationwide abortion ban and estimates that maternal mortality would increase by about 21% overall, simply because more patients are going to be forced into the pathway of continuing the pregnancy, which is inherently more risky compared to obtaining an abortion. And the maternal mortality would increase by about 33% for Black women and birthing people. And I think that's just, I just want to highlight, the disparities that Black, Indigenous, and other people of color face with regard to reproductive health outcomes overall, but in particular related to maternal mortality. We cannot be complacent about these disparities, and really more has to be done to address the role of racism in healthcare settings that contributes to these poor outcomes. And I think these efforts have to be even more urgent, given that people are being forced to continue unwanted pregnancies to term due to the abortion bans. So I'll stop there. Thank you, David.
Thank you, Dan. I'd now like to introduce Ghazala Moyeti, the founder and chief medical officer of Pegasus Health Justice Center. Ghazala?
Thank you, everyone. Thank you so much for inviting me here today. I am an OBGYN and abortion provider based in Dallas, Texas, and really at the front lines of abortion restrictions and the fall of Roe here in Texas and in my surrounding communities. So as we get into the discussion today, we're going to touch on hopefully all of the great points that Dan brought up. But really what I want to touch on right now is that communities like mine in Texas have been living in a post-Roe world or without the freedoms of Roe for quite longer than the Dobbs decision this summer, than SB 8 last year. Targeted restrictions on abortion providers or on abortion provision, trap laws, have been the mainstay of my clinical practice for over a decade and have dictated how abortion care is delivered in many states across the country for over 20 years. The reality is that access to timely abortion care in our communities is really a human rights issue and absolutely necessary for safe and thriving communities. And unfortunately, the communities that I serve have not had full access to their human rights and dignity in the medical space for quite some time. Abortion bans not only impact people that seek abortion care, but they also impact all areas of healthcare and have negative public health implications for all pregnant people. That is something as an OBGYN, my colleagues and I in Texas have always known to be true, that abortion bans trickle into all aspects of pregnancy care, even for people that have desired pregnancies but experience complications. And we saw that really magnified after the implementation of SB 8 last year, when clinicians and healthcare providers became fearful of intervening in emergent situations because they weren't sure if people were dead enough or dying enough to warrant emergency care under the fear of these new laws. So I think that the important thing to take home is that no matter what your personal opinion on abortion care might be, access to abortion care, community-based access to abortion care is critical for the health and safety of all pregnant people and all the people that we serve. I want to just illustrate maybe in a few sentences the real impact of abortion laws in our state, even prior to Roe falling, even prior to SB 8. And I'll just say it through just 3 sentences that describe 10 abortion restrictions that we were dealing with even before all of this. So Letty wants a medication abortion and lives in Midland, Texas, which is in the western edge of Texas. Letty drives 5 hours to Dallas to see me, where Letty pays $100 and I perform an ultrasound and find her to be 10 weeks and 0 days. Letty cannot have a medication abortion. Now imagine that this sentence was prior to SB 8 and prior to the fall of Roe. These are 3 sentences that actually describe 10 abortion restrictions that existed in Texas prior to even Roe falling. And I think that that really illustrates that this issue is, yes, about the fall of Roe, the Dobbs decision and what that means across the country, But the reality is that Roe was never enough for the communities that I take care of, and that even prior to the fall of Roe, a person living in Midland, Texas, or El Paso, Texas, or Abilene, Texas, struggled, jumped through countless hoops just to be able to get to an abortion provider, and then often were still denied their human right to decide when and how to be pregnant through multiple state level bans. I'll stop there and we can jump into the discussion.
Great. Well, thank you all for your introductory comments. We have a bunch of questions that were submitted by our participants prior to the webinar, so we'll sort of get into them right away. A lot in the last couple of years with the pandemic has raised issues about telemedicine and telehealth. What do you think the implications of the Dobbs ruling are for telehealth?
I'm happy to start,
Sure.
and others can jump in. I mean, I think a lot of people are asking whether there is a way to use telehealth to maintain access for people who are in states with bans or expand access. And, you know, so far that's, I think, going to be very challenging. But I mean, certainly, you know, in light of the restrictions, you know, as we're seeing more patients traveling, for example, to California, to other states that have, you know, more supportive laws, there is an important role for telemedicine in those states where telemedicine medication abortion has really become a standard of care. We have a great deal of evidence about the safety and effectiveness of this model. And telemedicine can be used in those states to potentially move some patients out of the clinic, out of facilities where abortions are being performed, so that there's more capacity to serve patients who are traveling. But so far, you know, it would be legally very difficult to provide telemedicine across state lines to patients in bans. These states not only have banned abortion, but they also often, most of them have bans against the use of telemedicine for providing medication abortion. It would be hard to maintain a license in those states. I will say that, we'll probably talk later about some of the shield laws in some of the states that have been passed. Massachusetts did just recently pass a law that does seem to allow some protections for the provision of telehealth across state lines. I think that remains to be seen how it will be implemented.
Great, thank you. Other thoughts?
Yeah, I think Dan brings up a great point that telehealth certainly has a potential to help free up space in clinics in states where telehealth is allowed. But for example, in Texas, telehealth has always been banned specifically for medication abortion, even when telehealth provisions were being expanded for other aspects of COVID healthcare. So opening up space for clinics in states with abortion provision is, you know, one of the many benefits of telehealth. But we also have yet to see telehealth really address disparities in healthcare across the board. So we don't have good evidence that telehealth expands care specifically for Black and Indigenous communities, people who are immigrants, undocumented. And so those are the most structurally oppressed groups of people that we care for. And it is not clear that these tools are actually the resource that those folks need.
Interesting. Sheila, go ahead.
You know, I think just taking it one step further, besides even just medication abortion, pre-op and post-op services for patients who need later term abortions. I think telehealth avenue is a really nice, in an ideal world, way to get maybe save a patient coming across state lines some time, you know, not taking as many days off work to kind of prepare them for the procedure and kind of get it expedite the process. I agree with Ghazaleh and Dan. It's you know, the legality of it is still you know, a little murky. I know for myself, this is how I do expedite my own patients in my practice into those later term abortion cares and try to get them you know, care as quickly as possible, because aside from, you know, the topic itself, it's extremely time sensitive, as I think everyone's pointed out. So I think the telehealth can play a huge role, and there's a lot of room for benefit there, but it's yet to be tapped into, and hopefully it'll be something that'll kind of transform the care that we're able to provide.
Interesting. I think 5 years ago, we wouldn't even have thought about it so much, right? But it's really become top of mind for all the right reasons. And I think Ghazaleh is right. It remains to be seen how it will do for some of these underserved communities. There seems to be some potential there, but we don't know yet for sure. So we'll see. So, at the Doctors Company, we're committed to helping medical professionals under normal circumstances navigate the complexities of today's practice environment. How has this decision added complexity? I think some of you mentioned this in your opening remarks, but how has it added complexity for you and others in your specialty?
Yeah, I can definitely start. I mean, certainly it has completely upended my practice, and not just as an abortion provider, but as a generalist OBGYN as well. Certainly I was providing abortion care here in the Dallas area prior to the SB8 decision, traveling to Oklahoma City to provide abortion care for people displaced from Texas and from the entire region. And now, my ability to travel and provide care is actually also in a legal murky area. But on top of that, my colleagues across the state are fearful about how to care for pregnant people with pregnancy complications that maybe weren't seeking abortion care at all. And so all of us as healthcare providers and OBGYNs know that nobody's body read the textbook, right? That like there isn't a definition even for medical emergency. Did you guys ever read a definition for what a medical emergency is? Right?
Yeah.
And that these laws, however, are written in a way that expect medicine to be cut and dry, that people's bodies follow a simple course, and that there is some aha moment where you can say, this is clearly an emergency and now I can intervene. And that never happens, especially not for pregnant people. We know that they're okay, and then they decompensate into the worst that you could possibly imagine. And there is no other area in healthcare that I can think of where we would literally wait for someone to decompensate before we offer life-saving treatment. That is the very antithesis of providing good healthcare. And so, my colleagues and I are really in a bind. Where should you put your allegiance? And I don't have I have my own answer, but this is a hard position, right? Do we serve to the best of our abilities and potentially put our own licenses, freedom, safety, careers at risk? And there's not a clear answer, and it will remain to be seen in the courts, really.
Yeah. It's so interesting. You talk about where does emergency begin, right? It sort of reminds me, we've used in the world of patient safety a lot, the analogy with the airline industry.
Right.
And people say this is not like flying planes. This is a great example of that. I think it's a little easier to define things when you're flying a plane than it is when you're taking care of a patient, right? Other thoughts?
Yeah, I mean, I can speak to that a little bit. I think, as someone in California, we are anticipating, as a practitioner in California, we're anticipating a huge influx of patients from out of state over the years as this plays out. So we are currently in the process of expanding our family planning services at our private facility, but there is definitely a lot of questions around, in general, every patient who contacts us from out of state, is this legal? There's always a process that goes around it. Or is there insurance from California, or is it from another state? Is there any kind of consequences that myself or my partners may bear? So it's unfortunately, created an extra step on our end. Certainly nothing compared to what practitioners are going through in other states, but I think there are some downstream effects that we'll feel. And even in California, I think it's important to remember that even in a state where abortion is a constitutional right, I am still surrounded by other physicians and healthcare providers who are very much against providing this kind of care. So it's still not, like a smooth sailing here. It's still a bit of an uphill battle. Again, nothing compared to what providers are going through in other states, but it is a new kind of path that we're paving here to try to accommodate, if at all possible. And then the next step is, how do we get patients here, right? The financial aspect of it. So.
Yeah.
Dan?
No, Sheila, you bring up really good points. I also practice in California, and you know, at our hospital, we're definitely seeing certainly many more patients calling, asking about obtaining abortion care, and it's definitely some increase. It has not yet been a surge. You have to recognize, I mean, San Francisco is far from the places that have so far banned abortion. I mean, during the period where services were essentially banned in Arizona, I think Southern California was really seeing something of a surge, but it's just been kind of a slow uptake, I would say, in the Bay Area. But I think what we're realizing also is that we need to do a better job of you know, helping patients navigate the complex medical system. I mean, you know, we need to invest in patient navigators, essentially, who can help patients who are calling to be able to figure out, you know, make sure that they're connected to the abortion fund here in California, that they're connected to whatever support or logistical groups in their states where they're located, to help them really get here as quickly as possible and navigate all the hoops that are necessary. So that's one need, and one kind of practice challenge that we're recognizing. I wanted to say one other thing, it hadn't been mentioned yet, it's just the challenge around training. You know, I work at a training institution, and really concerned about particularly the OBGYN residents, you know, for whom abortion training is mandatory. For family medicine residents, it's optional but recommended. And you know, there are many other trainees in other areas of medicine who are very interested in obtaining training in abortion care. And for those who are living in states where the abortion has been banned, that isn't possible. And according to one analysis, it's estimated that about 44% of OBGYN residents, about like over 22,600 OBGYN residents, are training in a state that is likely to ban abortion. And what's going to happen to them? I mean, we're getting a lot of requests for trainees to come to our institution. I mean, even during SB 8, there was a need for residents in Texas, and I'm sure Dr. Moayedi can speak more to that. But I think this is something that we also really need to think about, and think about how you know, physicians in private practice who do provide abortion care, but maybe haven't had trainees before, might think about potentially opening their practice to a trainee and partnering with a local residency program if they're located in a state where abortion is still legal. Because really, all of us are going to have to step up to meet the needs for training.
Interesting idea, having private practices do that. Very interesting. So let's talk a little practically speaking, and just giving advice to colleagues. So, you know, in high stakes, urgent situations, ectopics, preeclampsia, and so forth, delays in treatment could result in adverse outcomes for either the pregnant patient or the infant, depending on the timing. How might physicians prepare ahead of time to address these situations? And obviously, it's a little different depending on where you are, but any suggestions for physicians to prepare, to get themselves prepared ahead of time? Nobody wants to wait until they're faced with this if they can avoid it. Any thoughts?
Yeah, I think, you know, this is something that I've been dealing with for over a year now. And I think that everyone does their community a service by having these proactive conversations. This is something that with the hospital that I worked at, even prior to SB 8, we started talking about and really started gauging what people's values are, where their positions are, because this is not an easy to answer question, right? That there are situations where the hospital lawyers might have a different opinion than the hospital admin, might have a different opinion than individual providers. But ultimately, right, you're the physician. You're the one that will get arrested, but you're also the one that could, you know, refuse care that results in someone's death. And so ultimately, this is an important thing for each of us to think about, and think about what we might do, and to have very clear conversations with folks in our departments about, and to build policies preemptively that can capture all of these nuances, that state your values as an institution, right? many institutions waited, and then the reaction is out of fear, out of urgency. And those are the times when we most forget our mission and our values and our commitment to our communities, when we're acting out of fear and urgency. So even if you're in a safe state, and I use quotes there because I truly don't think that any of us are in safe states, that people are criminalized for pregnancy outcomes in California and in New York and in Oregon and in Washington, and that all of these places are in danger of losing the human right to bodily autonomy and abortion access. And so having those tough conversations, even when you're imminently safe, is really crucial to start developing those partnerships and building out policies that really capture your organizational values. What is your organization here for? Is it here to ultimately protect itself or to serve your community? And where is the nuance in between those two?
Dan, go ahead.
No, I think, Ghazala really summed that up very nicely. I think, we're currently doing a study where we're inviting healthcare providers to share stories of cases where, essentially poor quality care was provided because of restrictions that have gone into place since the Dobbs decision. So any healthcare provider can go to a website, carepostroe.com, and anonymously submit their story. And we just launched this a little over 2 weeks ago, and we've already gotten quite a few submissions. And it's so upsetting to read these stories. Ghazala has been living this reality, but just reading it, and a lot of the stories stem from confusion about what can be done and trying to react in the moment, because there hadn't been much planning done. And one lawyer who's on call during this shift gives one recommendation, and then the lawyer who for the hospital who's on call during the next shift gives a different recommendation. So I think Ghazala's recommendation to try to think proactively about these policies, and making clear guidance, like a tubal ectopic pregnancy, there should never be any delay in treating a tubal ectopic pregnancy. But yet we're seeing these stories of where there's confusion about whether that's allowed, and multiple people need to weigh in to give an opinion before treatment can be provided, which is really just shocking. But again, as Ghazala says, it's the physicians who are on the line in these situations, and it's a really tragic situation.
And I think I'll just add to what Dan is saying, that physician voices, clinician voices are really needed in these conversations. I think for me, prior to all of this, I really thought the lawyers tell us what to do, right? But that isn't actually how these conversations should happen. The lawyers bring us legal advice and legal opinions, and we also bring the voice of our community members and the people that we take care of, and the nuance of the science and the medicine. And that isn't, the lawyers we work with are great, but that isn't what their training is around. And so it's okay to push back. It's okay to say, what about this? What about that? It should be a back and forth dialogue, not just the lawyers told me no. That's the lawyers work for us, right? That they represent us in our ability to practice medicine. They don't tell us how to practice medicine.
That's such a great point. And unfortunately, physicians have been not so good at being active, right? Just forgetting the current topic. For years, we've had things foisted on us, and then we complain about it. But in all fairness, being a physician and going through training and taking care of people is all consuming, especially now. Medicine is so complicated. But I do think we need, as physicians, to basically start informing the public and lawyers and politicians about what it's like to practice medicine, so that we don't have to worry about what you said before, Ghazala, with it just says if it's an emergency. But that reflects the fact that people who don't treat patients don't really understand how things happen that way. Sheila, I don't know if you had any thoughts about this as well.
Yeah, no, I mean, I think the other kind of wrench in this, and what makes it a little bit more difficult, is that these laws are constantly, well, in the foreseeable future, will be changing. So there is going to be some change seen in other states, hopefully not in the states that abortion is a constitutional right, but keeping up with that amongst, like you mentioned, the patient care aspect can be a little bit taxing. So having a good source, Guttmacher Institute or Society of Family Planning, is always nice to kind of have at the forefront to help understand what the legality is in your state. But it is certainly a little bit more difficult. I agree. I echo both Ghazaleh and Dan. I think it's very important that we kind of take a more active role in stepping up and being the voices of our community.
Could I maybe add one other thing?
Go ahead.
Just one other piece of advice kind of related to this legal topic. It's a little bit different, but I alluded to earlier, is just recognizing what role we can play to stop criminalizing patients in healthcare settings who may be seeking care after attempting to self-manage their abortion. So the legal group, If, When, How, recently published a report where they identified over 60 cases between 2000 and 2020 of people who were arrested or criminally investigated, even jailed, for allegedly self-managing their abortion or helping someone else do so. And really the shocking thing is that in about half those cases, care providers were the ones who essentially referred the patients to the police, either healthcare providers or social workers. And so we really have an important role to interrupt that cycle. I mean, there currently is no jurisdiction that mandates reporting of self-managed abortion. And especially if patients are using medications to self-manage their abortion and presenting to a healthcare setting for evaluation or to figure out if the abortion was complete, generally these patients present exactly the way a patient looks who's had a spontaneous miscarriage. And in most cases, it's really not even necessary for us to know if the patient did something on their own to try to induce this pregnancy termination, or if it was just spontaneous. And asking patients, and particularly documenting that information in the health record, can put patients at risk. And so I think we should really ask ourselves, is this information necessary? Is it clinically relevant? Is it necessary to document it in the chart? And if it isn't clinically relevant, we shouldn't document it, because that's going to potentially put patients at risk.
So we talked about physician leadership. A lot of our viewers today actually work in hospital systems. I know certainly Dan does. What would you suggest to hospital system leadership they can do to support and protect clinicians and patients? Any thoughts about that? What would you tell hospital leadership?
I mean, I certainly, as someone in Texas, would beg, implore, and plead those in states where abortion is legal to look at your hospital level policies on abortion care and expand abortion access in your hospital where you can. There isn't a reason that every hospital in California shouldn't be providing abortion care right now. We don't actually have the infrastructure in this country to currently care for the number of patients that need abortions. With the number of states where abortion is becoming illegal, we need a huge expansion in our infrastructure, and that doesn't have to be brand new clinics built all over the place, right? That we already have that infrastructure in place, but so many hospitals and institutions have for so long depended on private groups to take care of that. And really, it's all of our responsibility to step up and expand care. Do you have an outpatient surgery unit? You should be doing procedures there. Do you have clinic space with procedure suites? You should be opening up for abortion services there. And hospital admin really need to get together to how they can really rise to this moment and need.
So just to echo on that, currently in terms of where I am in Southern California, I am an abortion provider, and I also have facilities where I can provide abortion care. However, despite all that, I'm still kind of at odds against an overall hospital culture. So definitely I echo, facilities and providers who are able to provide this care. It's important to get that prepared, but more importantly, some sort of education around which there's an effective cultural shift. So those people providing the additional support in this process are not looking at this as something to be scared of, something to be fearful of, something that they might get criminalized for. I think there's a huge need to educate not only the physicians and the admin, but also just the entire hospital culture. So I'm definitely, seeing that that is one of my biggest kind of uphill battles right now. I have facilities, I'm a provider, but it's getting the support staff to be on my side. And thankfully things are moving in the right direction, but it's harder than it seems because people don't look at it as an essential service. They don't see it as a human right. They don't see it as certain, a certain service that needs to be provided to a patient, just like any other procedure. There is always a little bit of that cultural backing that they have in their head, a little bit of fear because of all the politics. And so to be able to kind of educate them and to make them comfortable to provide the care that the patient needs is going to be very important. So I think a huge cultural shift, even in the hospital staff outside of physicians and the admin, is going to be important.
So go ahead, Dan. Go ahead.
No, I guess I was just going to add that, I think that there is also a role, obviously, hospital leadership in states with supportive laws, need to be really well informed about the legal situation in many of these states, including California, New York, Connecticut. These shield laws have been passed to protect providers who are providing care to patients who are traveling from other states. And so, of course, it doesn't reduce the risk to zero, but it does provide quite a few protections against civil penalties, against criminal penalties, protects our licenses, and depending on the state's law. So it's important that hospital systems become informed and well educated about these legal protections and don't just kind of immediately say, this is too risky, we're not doing this. And I also think that there's a role for health systems to be involved in the advocacy process to get those protections in place in states where they're not yet in place, but there's a potential to get them in place, and strengthen them in states where they have been put into effect. Because we certainly know the healthcare systems can be strong advocates when it comes to issues around reimbursement and things like that, but they should also be strong advocates around this too.
Great point. It also speaks to having physicians as part of hospital leadership, right? Topic for another day, perhaps. So Dan, I want to get back to your point before about training of residents. So, we've heard about an influx of residency and fellowship applications to West Coast and the Northeast. Are we going to see a brain drain? Talk about unexpected consequences, right? A brain drain of OBGYNs in restrictive states. Can we see that coming down the pike?
I think that's a real concern. I'm sure Ghazaleh can speak more to that, but we're certainly hearing from colleagues. Of course, people are very rooted in their communities and they don't want to leave, but they're being faced with really tough choices. And I think, particularly again, I want to hear what Ghazaleh thinks about this, but just how heartbreaking it must be to be in a situation where you're a physician who is training the next generation of clinicians, and you have to say, what we are doing here is not evidence-based care. We are providing poor quality care, and I'm sorry we have to do this, but this is what the state is forcing us to do, and that just must be incredibly heartbreaking.
Yeah, I'm definitely concerned. Just over the past year, at least, I think 4 abortion providers in my state have left the state. And abortion providers, right? We don't just provide abortion care, although even just providing abortion care is a huge feat in a state like Texas. But we have real ripple effects in education and the care culture in our communities as well. And prior to SB 8, I was training residents and medical students from really across the state. And right now they're turning to me and wondering, Where are we going to be able to go? What are we doing? How are we getting care? And so it's a concern as far as bringing in people to continue to practice in Texas. People are rightfully fearful of coming here to practice or set up shop. At least for my state, I can say that Texans are very proud. We love our communities. Many of the physicians I've talked to are completely distraught and not willing to give up. They're not, they want to remain, but who else we're going to be able to bring in is, a huge question for us. We definitely, I don't have the numbers, but we've definitely seen a drop in applications for fellowships and residency spots here in our state. And I'm sure that trainees are thinking about if they're going to stay here or not afterwards, depending on what kind of environment they have to practice in. And, we have to be real that also many of our trainees are starting their own families, and our ability to care for them safely and to keep them in a safe learning environment is being challenged over and over and over again.
It's an interesting way of looking at it, right? As looking at trainees and future physicians as both patients and future physicians. So I don't know, Sheila, if you have any thoughts about this brain drain potential.
Yeah, I mean, I don't know if I have much. I did all my training here in California. So I've had I'm fortunate enough to have had excellent family planning training. It's made me who I am today. But I think that family planning training is like at the pinnacle of OBGYN training. It's huge. It's something that you really don't get exposed to otherwise. And unless you're actually there looking the patient in the eyes, it's hard to kind of see the effect that this care has on a patient and her family and her future kids and just that entire ripple effect. So, I can't echo enough how important it is to have this in training. It made me attuned to the social impact, the economic impact, the political impact. It made me a more, I think, capable provider now to be able to provide these services, but also to be prepared for the uphill battle. So I think it's unfortunate, but similar to what, Dan mentioned, if there's potentially even space for private practitioners to bring on trainees. I know, a lot of us that provide this care are very passionate about it and would be happy to. I think there's some hoops we'd have to jump, but I think in an effort to increase the number of providers who are exposed to this level of care, I think that's one potential future outlook.
Yeah, and I'm going to put a shameless plug. If you're listening and you have space, my trainees are begging for training. Please reach out to me. I have really eager and dedicated residents that want to get this training and need places to go.
Thank you.
Can I just add one other thing? Is something that we're seeing, at least in Northern California, is a lot of interest suddenly among primary care providers and even among general surgeons who are interested in getting training in abortion care if there's a need for their services, which is great that they're stepping up and recognize that this is a service that they could potentially integrate into the care that they provide. It's just putting also, again, more strain on the limited training resources that are available. But hopefully this is something we're going to have to figure out.
And I think to Dan's point, it might not be that we need to be training every other specialty in how to do an abortion. I don't necessarily think that's the case, but I do think that this is a moment where every other specialty can learn about abortion care, can learn how it impacts the patients that they take care of. That even if you're a cardiologist, you need to know about abortion care. Even if you're a GI doc, you need to know about abortion care. Every single specialty, I literally can't think of one that doesn't need to understand the basics of abortion care and recognize who might need a referral or might need access or might need help, because people that get pregnant need all sorts of health care, and their comorbidities or other complications intersect with every single specialty.
Interesting. Go ahead, Dan.
Building off that, I just want to say, we do have some resources available if people are interested, like just a simple list of, where can you send a patient who, asks questions about how they can get a referral for a place where they can access abortion care, if they need financial support, if they have questions of, legal questions, where can they get that help? And we put together a simple list, and if anyone is interested, you can definitely send an email, and we'd be happy to send that to you.
Great, thank you. Let's just talk a little bit about the physician-patient relationship, something that most clinicians, certainly in my generation, that's sort of what ultimately, in many ways, got us into this to begin with, into the practice of medicine, that physician-patient relationship. And it's such an important partnership for making healthcare decisions. How do you think this whole situation is going to change or potentially change the physician-patient relationship? I think, Ghazaleh, you alluded to this before.
I mean, I think that this has certainly endangers the physician-patient relationship in many ways. Trap laws historically have inserted politics into physician-patient relationships. Even prior to SB8, right, I was required to provide state-based propaganda to people seeking an abortion, false information about pregnancy development and the complications associated with pregnancy care or abortion care. And so that has always been a concern, but now we're moving into an area where patients are afraid to tell their physicians or clinicians the truth about, right, accessing self-managed abortion, having a miscarriage, and we should be concerned that these laws are leading to people needing to lie to us specifically to preserve their own safety. And it will make it more challenging for us to provide health care. It'll make it more challenging for us to be trusted. Many people I'm seeing across platforms are saying they don't trust their doctor anymore to tell them certain things about their medical history, about their last menstrual period, because they are worried that their doctors are participating in surveilling them. And so it's really important that we position ourselves not as agents of the state, but as servants of our community. And I really can't implore that enough.
I mean, yeah, I think Ghazaleh really summed that up perfectly. But again, just to reiterate that this is not just an issue in the states that have banned abortion. This is an issue everywhere. And I think, as Ghazaleh mentioned, I mean, there have been cases of patients who've been criminalized again because of even things that the healthcare provider put in the medical record or referred to the police in states like California and Oregon and other states that have generally protective laws against abortion, I mean, for abortion. So this is something we need to be aware of really everywhere.
Great. So I'm sorry, could you have a comment, Sheila?
No, I mean, I just wanted to echo, Ghazaleh and I think they really summed it up. They did a really nice job. I think beyond even just the patient-physician relationship, I think it's the patient's autonomy over their own rights, their own body. I think it even goes down to that. It's really being threatened by what's going on. So I agree. I think it's our role as physicians to definitely be their biggest advocates and to make sure that beyond just advocating for their right for an abortion is just to be able to make their own decisions.
So we're getting towards the top of the hour. Just one last quick question. Just curious if you had any thoughts for your ED colleagues, emergency medicine colleagues, who are unfortunately faced with some of this before you are. Any preliminary comments? We may think about doing something focused on just ED physicians in the future, but any thoughts about suggestions for them?
I mean, abortion patients, people that have abortion care, rarely need emergency services or hospital-based care, but it does happen. Sadly, some of the biggest resistance I've received from my colleagues are from ER providers. I've had patients that need a blood transfusion before I do a procedure, and I've said, look, you have a hemoglobin of 5. You go to an ER, you're going to get transfused. And I've had ER physicians in my community refuse to transfuse people because they know they're going to get an abortion. And so addressing that among ER communities, talking about abortion and how ER physicians can gatekeep to people getting care is critical. Honestly, I could not believe that happened. And it really, it's happened more than once. And so talking about how to care for people with complications is important, but also how ERs can help support optimize people prior to their procedures is also critical. And talking about the value people's individual values in that, right? That again, our duty is to make sure that our community members are safe, not to gatekeep blood so that we can impose our own political beliefs on them.
Yeah, I mean, I totally agree with Ghazaleh that serious complications with abortion, even self-managed abortion with medications, are rare. But we do know that patients, especially if providers who had specialized in abortion care are no longer in the community, patients may have questions about whether the abortion is complete. They may wonder if a symptom is normal or not, and may seek care in emergency or urgent care settings. And so it's going to be really critical that emergency medicine clinicians, educate themselves and get more informed about what is the normal course with medication abortion. How much bleeding is too much? When does a patient need an intervention or not? Do you have to intervene just because in ultrasound you see a thickened endometrial stripe? And so these are the kinds of things that I think emergency medicine clinicians are going to need to be educated about so that they can provide better care for these patients who are presenting to them. And then, of course, they're going to also have to deal with these legal issues as well. Both in terms of trying to protect patients against being criminalized who might be self-managing their abortion, but also all the challenges that Ghazaleh has mentioned. And we're definitely, some of the submissions that we've gotten to carepostroe.com have come from emergency medicine clinicians talking about these really tragic situations that they're seeing in emergency rooms.
Great, thank you. So we've just got a few minutes left. I guess I'll ask each of you take-home messages for our audience. Sheila, you want to start?
Sure. All right. Well, thank you so much, David, Ghazaleh, and Dan. It was really honestly a pleasure to be part of this webinar and to hear from you guys. This is a topic that affects a quarter of women. A quarter of women will go through some sort of abortion by the time they're 45. So it is definitely not something to ignore or brush under. I think there are some avenues for big change, hopefully in states, including my own, California, where we can actually help with foreseeable challenges or influx of patients. But it is going to take some work, and I think it's beyond just setting up the infrastructure, but also putting forth a cultural shift or a cultural change to one that's more, fear-based, as Ghazaleh mentioned, and to something that's a little bit more structured and prepared for what's to come. I think that's going to involve a lot of work from those of us who provide abortion care, and I think the time is now. So I really appreciate you guys including me in this webinar. It's a pleasure, and thank you so much to the Doctors Company team for putting this together.
Sorry, Dan, final thoughts. Yeah, thank you so much for inviting me. This is a really interesting discussion. It's a really incredibly demoralizing time to be providing any kind of healthcare, but particularly healthcare for people with the capacity for pregnancy. But this isn't an unprecedented moment. I think that there are things that we can learn from the pre-Roe era. I think there are things that we can learn from our colleagues in Latin America who've been living under really restrictive laws related to abortion care for a long time, up until recently, where they've actually have liberalized some of their laws. But I think there are things that we can learn from them about how physicians have, and clinicians have, and social workers have stood up to care for their patients, even in the face of restrictive laws and facing the potential for being jailed. And I think it kind of remains to be seen what kind of activism will we see in the medical field. But I think there's just so many more discussions to be had about this and things to be learned as this moves forward.
Thank you, Dan. Ghazaleh?
Thank you so much for having me. Thank you to my co-panelists. Much love and respect to you both. I think, I just want to leave people with the nugget that, let this moment radicalize you, that we saw from COVID, that science and evidence often might not sway people, and that we are at a moment where these sorts of laws, these sorts of restrictions, they're not going to stay with abortion, right? That they are moving into all aspects of healthcare, into all aspects of our daily lives, into our ability to be free and live in a thriving, healthy way. And so let this moment radicalize you, whatever it is, right? It doesn't, you don't have to, I would love for you all to join in this fight. And in for expanding abortion access, but it doesn't have to be that. But be open that this moment is one that calls on us to not only serve our patients in the exam room, but to serve them outside of the exam room too.
Thank you very much. Well said. Thank you so much to all three of you, Sheila, Dan, Ghazaleh, for joining us. We really appreciate your insights and your expertise. And this brings our webinar to a close. We hope you've enjoyed today's presentation. Again, special thanks to our guests, Dan Grossman, Ghazala Moyeti, and Sheila Dejbakhsh. Please join us for our next webinar, Solutions for Reducing Racial and Ethnic Disparities in Healthcare, Tuesday, November 1st at 4 p.m. Eastern Time. The webinar will explore the stark inequalities in healthcare and offer insights and solutions to achieve better outcomes and reduce disparities. Moderated by Ron Wyatt, Vice President and Patient Safety Officer for MCIC Vermont. The webinar will feature Lakshmi Krishnan, internist and cultural historian of medicine at Georgetown University, where she's the founding director of the Medical Humanities Initiative. Alongside her will be Elizabeth Howell, professor and chair of the Department of Obstetrics and Gynecology, Perelman School of Medicine at the University of Pennsylvania. You should have already seen an invitation. You can look for more information about this and other events on our website, the tdcgroup.com, in the Insights section. We look forward to seeing and hearing from you soon.